Hello, I'm Martyn Caplin. I'm Professor of Gastroenterology and Neuroendocrine Tumour Biology and lead the Neuroendocrine Tumour Unit at the Royal Free Hospital in London. I'd like to thank Cathy Bouvier and Neuroendocrine Cancer UK for the opportunity and the honour to give this keynote speech on research and clinical trials in the UK and across the global community. Just as a background, and here's Cathy, and she was my senior nurse. I stole her from the gastroenterology department at the Royal Free Hospital back in 1998, I think it was. And she came to work for me as I just set up at that time the Neuroendocrine Tumour Unit at the Free. And Cathy was a fantastic nurse, and we had set up the first patient support group, Living with Carcinoid. I love that name in terms of patients being able to live with the condition. And it was set up with Liddy Oldroyd, a patient producer of Drop the Dead Donkey, Gimme, Gimme, Gimme. Her husband, Peter Gwilliam, who's still a senior patron of Neuroendocrine Cancer UK, other patients at that time, Sue Bailey, Catherine Calamis, and so many more. And this was really fulfilling for me, but just to see Catherine, the way she ran that was something fantastic. And so Catherine then went on to bigger and better things with the founding the Net Patient Foundation. And of course, now we have Neuroendocrine Cancer UK, and she's done an amazing job there. And of course, she's also president of INCA. So I'm incredibly proud of Cathy and what she's achieved. And she is a fantastic ambassador for neuroendocrine cancer patients. And this is what it's about. Here's a patient, Barry, back in the 1990s, who was skydiving with his neuroendocrine tumor and having that living with carcinoid. And this is a letter I wrote about him. I really can't keep up with Mr. Busby in terms of his skydiving, his scuba diving, and his skiing, usually all in the same week. I'm not saying that all our patients should be doing that, but that's what we aim for in terms of trying to keep a quality of life, and so that our patients can carry on doing what they should be doing. And that involves really having the best quality care, evidence-based practice, learning from our experiences, and translating research into therapy to enhance patient care and also their quality of life. And so this talk, in many respects, actually, I want to dedicate to those patients no longer with us, because I think one's always made it something that one's tried to learn from all our patients. And over the years, I've always reviewed every patient. And when the outcomes haven't been so good, we've learned something, so that every patient has mattered and contributed in one way or another. And that's why research is so important. And I want to put that today in context of clinical trials, but in practical management. I'm not going to just give you a list of clinical trials that are ongoing or that have just happened. It's going to be putting it in the context of actual management for patients. These are my disclosures. And how I'm going to do this is talk about the background developments to history to neuroendocrine tumor advances, diagnosis. I want to update you on biomarkers. People talk about liquid biopsy, what do we mean by that? Some updates in imaging, even surgery, actually. Looking at, although there's not formal clinical trials, looking at published data in areas related to advances in surgery that I think are important. Treatments, looking at current treatments that have just been published, new treatments such as the immunotherapies, and put that into context. And personalized medicine and genomic profiling, which everyone talks about, but also discuss the complexities of that. And this is a slide actually from Charlotte from Uppsala, showing the advances over the last 40 years in neuroendocrine tumors, starting originally in the 1970s with the chemotherapy, but then going on to the somatostatin analogs and the molecular targeted agents and the new treatments that have happened over the last 40 years. In fact, Chrissy Thirlwell had a nice summary slide in a recent paper where she showed not only the therapeutic advances, but also the advances in molecular science over the last years, and also the future perspectives as well. And many of these future perspectives I'm going to be talking about today. The core of all of this is the patient, and all patients should be seen within the multidisciplinary tumor board, and the patients need to be informed of the outcomes, and the MDT coordinator, the nurse, particularly the nurse, are really important in coordinating all of this and informing patients and the referring physicians. But also, actually, as a whole round of it, all patients in an MDT are considered for clinical trials and for contributing to research. That's certainly our practice. So what are the choices of therapies for patients? And in what context do we choose those therapies? And that involves looking at the pathology, the amount of tumor a patient has, the other conditions that patients might have, the expression of the somatostatin receptors on the surface of the tumors, as noted by their octreotide scans or gallium octreotide PET scans, looking at patients' previous therapies, how functional the tumor is, and does it make hormones causing syndromes, carcinoid syndromes, insulinoma syndromes, and so on. How fast is the tumor growing? What's the progression rate? Circulating tumor biomarkers, how can that inform our choice? And looking at other new novel biomarkers, and we'll discuss all of that and try and put that into some context. You'll be aware of the classification of neuroendocrine tumors into low, intermediate, and high grade. And so we've got G1 tumors, G2, G3, based on this Ki-67 proliferation index, which is in effect how rapidly the cells are turning over, with less than 3% being very low to greater than 20% being at the higher end in terms of the way the cells are turning over. And then you've got the poorly differentiated neuroendocrine carcinomas, where these tumors look different to typical neuroendocrine tumors and hence are called poorly differentiated, and still have this rapid, even more rapid Ki-67 growth turnover rate. There is another condition called MINEN, which is a mixture of neuroendocrine tumor and other cancers, which I'm not going to be discussing today. And there can be some difficulty in choosing management in the higher grade, the grade 3 neuroendocrine tumors, between that well-differentiated and poorly differentiated tumor. And there is an overlap in this Ki-67 as you move and progress potentially from a well-differentiated to a poorly differentiated tumor in a small proportion of patients. You know, the biology is really interesting, and this is an old slide and study, but you can see from it in red here at the top that says GI net and pancreatic net opposite it, that there's completely different genes involved with gastrointestinal nets versus pancreatic neuroendocrine tumors on this heat map of gene expression. Similarly, when you compare malignant and benign neuroendocrine tumors, there's a different heat map as well. So from 20 years ago, there was an understanding, certainly 10 years ago more, a difference and an understanding of the difference of the biology and the genomics between different types of neuroendocrine tumors and benign and malignant neuroendocrine tumors. And we know, for example, that different genes are expressed in pancreatic neuroendocrine tumors as opposed to pancreatic adenocarcinoma. And you can see these differences, and we'll be talking about some of these genes a little bit later on. And I've pitched this talk. I know there's doctors, nurses, and patients families going to be listening to this, and I've tried to pitch this as a level where we're going to talk about all these key advances, but try and make it understandable as well. That's the objective of it as best I can. So let's start off with the circulating biomarkers. You'll be aware of chromogranin A as the standard biomarker that we use today, and it's elevated in many patients with neuroendocrine tumor and seems to correlate with tumor growth. It's involved as a chemical in the sort of packaging and the secretion, the release of hormones by tumor cells. And there are individual biomarkers, so we measure in the blood or more often in the urine in patients with carcinoid syndrome, 24-hour urine, 5-HIAA. If you've got insulin secreting neuroendocrine tumor, we can measure that, and some of the gastrin and other hormones as well as appropriate. So the chromogranin A, currently the one in use virtually all over the world, is really a reflection of the level of chromogranin A is a reflection of tumor burden. So the more the tumor, the higher the chromogranin A. But overall, it has a low sensitivity and specificity, so a lot of false negative results and also a lot of false positive results if patients are taking other medications such as proton pump inhibitors, or omeprazole or lansoprazole can give false positive results. So we've discussed the biomarkers, the chromogranin A, the different chemicals released by neuroendocrine tumor cells. There are other molecular biomarkers which I'm going to talk about, which are the new advances. And on a biopsy, we can stain for different biomarkers as well, and I'll discuss that a little bit as well during the talk. So perhaps the biggest advance that everyone's talking about is the NET test. And what that is measuring in the blood 51 fragments of neuroendocrine tumor genome, if you like, the RNA transcripts as they're called, and that can be measured in the bloodstream. And that has very good sensitivity and specificity. There's very few false negatives and very few false positive results. I'm just going to walk you through how the NET test works. So you take a blood sample, and within that blood sample, it's measuring the genetic release from the tumor cells of from patients with neuroendocrine tumors of fragments of what's called RNA. And first of all, the test separates out the neuroendocrine tumor recognition versus normal. And you can just, so that will score whether you've got a neuroendocrine tumor or normal, depend on whether there's these fragments in your bloodstream. And then it goes on to what's called an omic index, which looks at these messenger RNAs, and with that it can predict how much there is, what the balance is of these RNA circulating transcripts in the bloodstream, and make a score as to then how active, how much there is in the bloodstream. And so therefore it comes up with this NET test risk index, which scores as low, intermediate, or high. And that's said to be useful for diagnosis, but also if you've had an operation for recurrence. It can be used for monitoring, and we'll discuss that in a little bit more detail. And also prediction as well, and whether or not a patient might respond, to example, for PRRT. So here we see that the NET test in red is far more specific and sensitive than the chromogranin A in various experiments in both intestinal and pancreatic neuroendocrine tumors. In this study, looking at bronchial neuroendocrine tumors, you can see that in disease-free patients, there's very low expression here of the NET test. In stable disease, it's moderately upwards, and then high in patients who've got progressive disease. Whereas for chromogranin A, you can see actually there's no real discrimination between disease-free, stable disease and progressive disease. And that's the problem with chromogranin A. And this part of this NET test called PPQ, it's a signature of 5 messenger RNAs, can be used actually to predict whether or not a patient's going to respond to PRRT. and it's proving to be quite effective in 3 different centers who've trialed it, but again needs to be validated, but very interesting for the future. So what about the realistic utility of this test? In patients who have just got watch and wait, so some patients are on no treatment and it's just watch and wait and we'll see what happens because it's a slow growing tumor. If the net test was low, then you could see that in those patients actually watch and wait turned out to be good because you didn't have to do anything and there was no management change in 25 of those patients. Where there was a change, then the patient went on to have stable disease. So 26 out of 27 patients benefited from knowing the net test score that it was low. But when the net test score was high, these patients benefited because say, right, you've got a high net test, so we're going to change your management. So whereas they would have otherwise progressed, they maintained, because of the change of management, stable disease. And those patients who didn't have a change in their management, all of them progressed. And similarly, treat those undergoing active treatment. If they were on an active treatment and they're somatostatin analogs, octreotide or lanreotide, and they had a low net test score, actually, then they didn't need a change in their management at all, and those patients maintained their stable disease. If, however, they had a high net test score, then if you change their management, so you went from octreotide to another molecular targeted agent or chemotherapy or PRRT, then those patients did well with at least stable disease in their follow-up. And if they didn't have a change in their management, despite that high net test score, then these patients progress. And so this suggests that this net test score could be something very useful in the future. It's been further refined this year with updated gene information. This is originally was derived in 2015. But similarly, with this new net test score, and Drs. Kidd and Modlin have come up with this thing called prognosome, which looks at the based on prognosis and the biology behind it. Terrible name, but this prognosome is made up of these different parts of these circulating messenger RNAs, some which are effective for fibrosis, for metastasis. They come up with fibrosome, metastosome, whether it's going to metastasize, genes for proliferation, proliferome, and so on. And by putting this all in their net test score, again, as I showed you on the previous slide, it helps define whether or not patients can continue watch and wait, or whether if this prognosome high net test score, they need to have a change in their management. And I think this could be useful for the future. It's still considered in trial, I suppose, and the costings of it need to be sorted out. There are other biomarkers. We've been interested in circulating tumor cells at the Royal Free Hospital with Tim Mayer, Mo Khan, and showed that for circulating tumor cells, which is, as it sounds, circulating cancer cells in the bloodstream, if there are patients who have no circulating tumor cells, they did better than patients with circulating tumor cells. And if for patients on treatment, there was a fall in their circulating tumor cells by 50%, then these patients here did better than where there was no fall in their circulating tumor cells. So this is not as far as advanced and not as easily available as the chromogranin A or net test, but looks interesting. And there are a number of papers published related to this, also in other neuroendocrine cancers such as Merkel cell carcinoma, and also small cell carcinoma, and in other cancers where it's shown to be useful, but not really as easily available. You've got circulating tumor DNA, so actually the DNA from tumor cells there, and I think this again is not as far advanced at all as the other genomic assays or biomarkers, but it was quite interesting because there was a patient who was suffering from a rectal neuroendocrine cancer, and the DNA for this what's called BRAF600E mutation was able to be detected in the urine. And then this patient was treated with a BRAF inhibitor, so a drug which could specifically inhibit this abnormal circulating DNA, if you like. And the patient responded with that, with a fall in the DNA level in the urine. And that's quite appealing for the future in terms of being able to consider markers which are easily available and interpretable. MicroRNAs are becoming a topic of increasing interest, and there's over 2,000 microRNAs, again derived from the DNA, and they regulate about 1/3 of the genes, in fact, within the genome, and they're associated with many different conditions. And the microRNAs themselves have various jobs regulating the way that the genetic information is activated or suppressed. And it's been shown in a variety of cancers here on the left to be prognostic and diagnostic, but also in neuroendocrine tumors now. There's quite in relatively small numbers of patients, but there is increasing evidence for microRNAs correlating with chemoresistance, with so resistance to chemotherapy, but also being prognostic in terms of metastasis and and the grading of tumors as well. So, but there's lots of different microRNAs, and it's trying to define, well, which are the most relevant, how easily can they be measured, and how commercially viable is it? And that's not the situation at the moment. I just want to mention epigenetics, which really implies that over on the outside, derived from Greek epi, and genetics from how it affects so things on the outside of the genome, if you like, that affects the overall functioning of the genome. And we're going to be talking a little bit about ATRX and DAX, what a great name, domain associated protein. And these are tumor suppressor genes. So they suppress the normal coding so that then the tumor can grow, if you like, out of control when there are mutations. So epigenetics is really something that can affect and be affected by chemicals from the environment, various pharmaceuticals, but there are changes in this epigenetics as you get older, and even diet can have an effect. And that's an interesting area, which I'm not covering today, but in terms of the effect of diet on the way tumor cells work, and undoubtedly it does have an effect on this, but probably via the epigenome. And so you have an area here you've got on the outside, which can be affected. This is the epigenetic changes. So you've got methylation, DNA methylation. Here's your genome here in purple. And you've got these histones here. And these histones are proteins around which the DNA folds or winds around to keep everything nice and compact. But actually, if there's changes in these histones, for example, it could be due to drugs, it could be due to diet, it could be due to some infection potentially, then you get modifications in these histones, which causes unraveling of the DNA and then activation of genes on the DNA. And there's many health conditions which can be have an impact on that. And DAX and ATRX have been shown actually to be, if they're present, in terms of DAX and ATRX, sorry, negative tumors have distinct patterns which you can stain for on a biopsy. And these DAX deficient tumors tend to have poorer prognosis, but also actually these patients may, from work from Chrissy Thirlwell and many others, may not respond so well to therapies such as everolimus and sunitinib. So this is an important area which is coming into use. So we can say that the advances in biomarkers is the NET test, but we need validation. We need to understand the costing of it better. Currently, obviously, it's new and expensive because of the scalability is small at the moment. And we have to determine the availability. And you've got ATRX and DAX, which could be checked by on a staining on a biopsy, which may be prognostic. So let's move on to imaging and radiology. And just patients will all get their CT scans, but actually you can be a bit more sophisticated now, and there are various platforms whereby you can assess a CT scan, looking at the density of the tumor there, how irregular the margins are. And this can all be prognostic in terms of whether the tumor is going to grow, how aggressive the tumor is. And this is a new area of understanding, and is being currently worked out, but I think actually has an important application. You'll be aware of the nuclear medicine imaging. Here's a gallium-68 dose-to-tape PET scan, where you can see this patient has multiple tumors scattered through the bones, and it's much more clearly seen than on the old-fashioned octreotide scan, and that's a big advance of the gallium octreotide PET scan. And we had shown previously, in fact, that by having the gallium dose-to-tape PET scan, it changed the management in patients in over 40% of patients with different tumors. So this is a really important test and in advance, and is really a must, I think, for all NET patients. For high-grade neuroendocrine tumors, the FDG PET scan, which is really functions on the way the cells are turning over, how rapidly by metabolism of glucose, fluorodeoxyglucose PET scan, as a metabolism of glucose. And the PET scan lights up high-grade tumors, whereas the gallium octreotide PET scan binds to the octreotide, to the somatostatin receptors on the surface of the tumors, and lights up those well-differentiated tumors which have the receptors sitting on the surface, and lights and binds to them, lights them up as hotspots. So the gallium octreotide PET scan, you can see here in this top panel, lights up in this well-differentiated tumor, whereas the FDG PET scan is negative in the liver, because this is essentially a grade 1 low-grade tumor. But later on, in fact, this transformation of this tumor, it's still got areas of well-differentiated lighting up on the gallium octreotide PET scan. But there's some poorly differentiated grade 3 tumor here, which is becoming more active, and so the FDG PET scan is positive. And now combining FDG PET scan and the gallium octreotide PET scan can be very useful to say what management a patient should have. So in group 1 here, this patient has got multiple lesions lighting up in the liver, nothing on the PET scan and on the FDG PET scan. So the gallium PET scan positive, well differentiated, very typical neuroendocrine tumor. FDG PET for aggressive tumor, not there. This patient responds well to PRRT because the lutetium binds to the well differentiated somatostatin receptors on the tumors. You've got a patient who's got both scans being positive. So this patient may be suitable for PRRT or other treatments such as chemotherapy. And we have to be more aware that this patient may have more aggressive disease because the FDG PET scan is positive. And here in this final panel, where the main burden of the liver, there's very little uptake compared to big area here. These two, this is the kidneys here, but this area of the liver has a lot of tumor, which is FDG positive, but gallium PET negative. So this is a more aggressive tumor, and this patient would need chemotherapy. So by understanding the PET scans, you can decide what is the most appropriate therapy for patients. And just recently, in the last couple of months, there's been this paper showing in patients who had the primary, they didn't know where the primary was. The gallium PET scan was able to identify the primary in these patients in over 80% of the patients, which turned out to be in the pancreas and small intestine in most patients, 27% and 37% for small intestine, and the other sites as well were identified in this study. And so in patients where you can't identify the primary, the gallium dose-to-tape PET can be very helpful in doing that. The other advance in nuclear medicine has been for insulinoma with something called exendin-4 or glucagon-like peptide. It's very difficult to identify the small insulinomas in the pancreas, but this chemical can identify, binds to insulinomas, and so you can identify on PET scans with this chemical attached to it, the exendin-4, it binds to insulinomas. It's a new way of being able to identify insulinomas because it's so new. It's only available currently in Basel and a couple of other centers internationally. We sometimes perform endoscopic ultrasound on patients. So we have an endoscopy with an ultrasound probe at the end of it, and that's useful for staging. And it's very helpful in staging and taking biopsies, for example, from the pancreas, and being able to identify lesions such as insulinomas. The advance, though, in this area is whether or not one can perform radiofrequency ablation. So down the endoscope, going through your mouth, and you have the endoscope, you can identify the tumor in the pancreas. Can you put a little probe down into that tumor in the pancreas with radiofrequency ablation and burn away the tumor, if you like, and so that the patient doesn't have to have an operation? So there are small studies in small numbers of patients, which have been showing, though, that actually for small tumors, probably less than 15 millimeters, that this might be a technique that could be considered in the future. It doesn't, however, treat patients who've got lymph node spread or more distant spread. So if patients got very localized tumor with no lymph node involvement, then this could be a potential option for the future, and with currently little side effects, but I think we have to see results in many more patients. Let's move on to the other treatment options. I'm going to start off, though, with surgery. I think the biggest advance in terms of the consideration of surgery is for the high-grade neuroendocrine tumors. In the past, the dogma has been, actually, if you've got a grade 3 neuroendocrine tumor, you really don't need to consider debulking them because the outlook is poor in these patients. I would say, actually, with this recent paper that's come out in the last couple of months, that actually we should be considering surgery in selected patients, even in metastatic disease and even in debulking patients, and provided the individual is fit enough and provided there are treatment options available for that patient. And that surgical debulking for the well-differentiated neuroendocrine tumor, in fact, the overall survival in this group of patients with more aggressive tumor was over 40 months. It was over 3 years. Many patients doing better than that as well. And that even in the higher grade neuroendocrine carcinoma, you could still consider surgical debulking. And if they were given what's called adjuvant chemotherapy as well, so after the surgery they had chemotherapy to control the residual disease that might be there, then those patients did better than those who just had debulking surgery without chemotherapy. And I think this just opens up a whole new thought process for the more aggressive neuroendocrine tumors and whether we could consider debulking surgery. Previously, not many of us were necessarily considering that, and I just think we have to open our minds a little bit more to that. There is a clinical trial ongoing in neuroendocrine tumors for low-grade neuroendocrine tumors, and looking at patients who've got neuroendocrine tumors in the pancreas of less than 2 centimeters in size. It's quite likely that less than 2 centimeters in size, the chance of that tumor metastasizing, spreading is very small. And so therefore, there's the study to look at that called the ASPEN study. And this is ongoing in the UK and across Europe, looking at grade 1 and grade 2 pancreatic and neuroendocrine tumors. And really, we're just surveying the patients to see what happens. And if the tumors grow, then these patients can have resection, and we're looking at the outcome. So many patients with small neuroendocrine tumors of the pancreas, where there's no evidence of spread elsewhere, will go into this surveillance protocol. For intestinal neuroendocrine tumors, one of the main problems is desmoplasia. It's fibrosis. You can see this is the scarring, fibrosis here, the desmoplasia, which can cause twisting of the bowel. It can also, here you can see the tumor here, a bit of calcification. It means it's been there for a long time. These strands coming out here, which are twisting and pulling on the bowel, but also, in fact, strangulating the blood vessels. Here's normal looking blood vessel, and here's the blood vessel being strangulated by this desmoplasia. And this means that this patient can get complications such as severe abdominal pain, bowel obstruction, all due to this desmoplasia. And it's much under-researched and ill understood. Here's a gross example of a patient here, and you can see the tumor and the stranding and the way that it's pulling on the bowel and what potential that has for twisting, causing obstruction, strangulating blood vessels. And we know that patients who've got this desmoplasia, this mesenteric fibrosis, tend to do worse than patients without it. And the reason being that the effect on nutrition, the effect on all the blood vessels and pain, and the patient just being increasingly more unwell because of it. So it's incredibly important that we make advances in this research. And so we and other centers, we collaborate actually with a group in Rotterdam, but there are other centers as well investigating this area. And we're beginning to understand it a little bit more in terms of what chemicals are involved in this desmoplasia process, looking at what other cells are involved, cancer-associated fibroblasts, other macrophages. And so we're understanding this a little bit more. And now there are we've identified various factors, and there are ways now of targeting some of these factors, and we have to see how we can target and get better treatments for these individual factors to see if we can reverse and stop the progress of this scarring and desmoplasia. And so this is an area of very exciting ongoing research. Moving on to the medical treatments, there are a number of approved medical treatments by both the European Medical Agency and the American, the FDA. And you've got this sandostatin LAR and lanreotide, the somatostatin analog, sunitinib, and everolimus, which are called molecular targeted agents, tyrosine kinase inhibitor, mTOR inhibitor. The PRRT with lutetium, and then you've got a whole range of chemotherapies which are also approved. But there's a lot of newer drugs which are currently undergoing treatment and not yet approved. Many of them are similar in the way that they work in inhibiting the enzymes, and there's also what are called small molecules and anti-angiogenesis agents as well, which are not yet licensed, but could be interesting in how they're used in patients with neuroendocrine tumors. You'll be aware of octreotide and lanreotide as the first-line go-to for control of symptoms, but also have been shown as long ago as over 10 years ago that there's anti-tumor benefit in patients who are on octreotide LAR versus patients who are on placebo in terms of the anti-tumor benefit. And similarly for lanreotide, it's a good anti-tumor agent, so patients did much better if they're on lanreotide rather than on placebo. For both pancreatic and intestinal neuroendocrine tumors, grade 1 and grade 2 neuroendocrine tumors, and whether there was small volume or larger volume liver metastasis. So these were big advances in terms of neuroendocrine tumor biology. And we know for lanreotide that in the study for across neuroendocrine tumors, that the patients who were on lanreotide, before their tumors grew further, they had on the lanreotide 32 months before the tumors grew, whereas in the placebo group, it was half that, around about 18 months. But in the placebo group, when the patients then went on to lanreotide, their tumors didn't grow for at least another 14 months, showing the benefit even in actively growing tumors of adding in lanreotide. There is a study called lanreotide Autogel, the Clarinet 40 study, which has just been published. The results have just come out in abstract form. And this was in patients who were on, being investigated, who had progressive pancreatic or midgut neuroendocrine tumors. They were on their lanreotide 120 milligrams. And the question was, well, if you increase the dose to 120 milligrams from every 28 days to 120 milligrams to every 14 days, in essence doubling the dose, could that be effective? And yes was the answer. By doing that, you maintain the tumor stability for a further 8 months on average in those well-differentiated tumors with a Ki-67 proliferation index less than 10%. And so on average, you could extend between 6 and 8 months by just doubling the dose or giving the lanreotide Autogel every 2 weeks instead of every 4 weeks to keep the tumors are stable. So that seemed to be a reasonable way forward in terms of easier management for patients for the next 6 to 8 months, and sometimes a little bit longer than that. There's an interesting study called the Reminet study, which is a European double-blind placebo, so the lanreotide versus an inactive placebo, looking at what happens if you give patients lanreotide after they've had treatment, for example, chemotherapy for their neuroendocrine tumor. And so you have your treatment with your chemotherapy. Is there any benefit of giving lanreotide, or do you just stop the chemotherapy and nothing else? So that study is yet to report, but that could be a very interesting study in terms of affecting patient management in an easy way. This is just, don't worry about this slide, but it's of a new compound in clinical trials called PEN-221. This, like octreotide or lanreotide, binds to the somatostatin receptors, but in addition to having just something that binds to the receptor, it's carrying if you like, a chemotherapy agent with it as well, called DM1. And this combination is in very early phase studies, but there is some hint that it works in patients with neuroendocrine tumors. In this example, you can see a patient had a fall in their chromogranin A, a fall in the other neuroendocrine tumor marker, NSE, neuron-specific enolase, and a fall in their circulating tumor cells. So we have to work out the right doses, and this is in very early phase, but it's an interesting way of combining with a somatostatin analog, octreotide or lanreotide, attaching to it a chemotherapy agent which goes to neuroendocrine tumors. We have PRT, which is attaching a radioisotope to neuroendocrine, to the octreotide, which goes to the neuroendocrine tumors, and we'll discuss that a little bit later on. But this way of carrying a chemotherapy drug, if you like, is something that's interesting for the future. We know currently in use many patients already on sunitinib and everolimus for many years, going back to 2011, when the clinical trials showed the benefit of sunitinib and everolimus in patients with pancreatic neuroendocrine tumors, and for everolimus more recently in intestinal neuroendocrine tumors. What's interesting, though, is that for patients on sunitinib, actually it still works even if you were on octreotide or lanreotide before. And even in patients who'd had chemotherapy, if they go on to sunitinib, there's still benefit of sunitinib in patients who've had chemotherapy. So that's good to know, and means that there's an extra treatment option. And similarly for everolimus, if patients have been on octreotide or lanreotide before, actually by treating with everolimus after that, then patients can have good response. And similarly, it still works after chemotherapy. So again, the question is, do you give treatments or everolimus before chemotherapy or after chemotherapy? What's the order of treatment for patients? The other thing that we need to understand better is ethnicity. That, you know, different ethnic backgrounds, patients respond because there's different genes in different ways. And there, for example, in East Asia, rectal neuroendocrine tumors are much more common than intestinal neuroendocrine tumors. Intestinal neuroendocrine tumors, so the small bowel intestinal, midgut neuroendocrine tumors, much more common in Europe, and rectal neuroendocrine tumors, much more common in East Asia. And so then the question is, well, does that have an impact between ethnicities on how drugs work as well? And certainly from this study, it showed actually that everolimus was equally effective in patients from Western or East Asian ethnicities. But I think we have to understand this more in lots of different ethnic backgrounds for all types of therapy. So what's about the order of treatment? You have the Sequitur study by ENETS, which is in patients with progressive disease. They go into either everolimus or chemotherapy with streptosis and 5-FU. And then if they progress, the everolimus group will go on to the chemotherapy. The chemotherapy will go on to the everolimus, the oral tablet. And so we're trying to understand, does it matter which one you give first? And so we hope to have some results from that over the coming year. Just to mention another big study that's ongoing in Europe is of a new tyrosine kinase inhibitor, a new drug not too dissimilar from sunitinib called axitinib, which is undergoing a trial in grade 1 and grade 2 non-pancreatic neuroendocrine tumors versus placebo to see if this new drug is something else that we can add to the armory of treatment. The more drugs we have, then obviously the better it is. What about chemotherapy? The standard chemotherapy for well-differentiated neuroendocrine tumors these days is a drug called temozolomide, often in combination with a drug called capecitabine. The appeal of this is that it's a tablet, and you see good response rates across, particularly for pancreatic neuroendocrine tumors, but also in some patients with intestinal neuroendocrine tumors which have spread. The interesting aspect of it is can one predict which patients to give this temozolomide to? And there's a special enzyme or chemical in cancer cells that if you're deficient in it, then actually the temozolomide works better. So here, where the MGM is present, actually the temozolomide response wasn't at all good in 16 patients, none of them responded. Whereas if it was missing, then here in the tumor, then actually the response was good in that 4 or 5 patients responded. And there's been a more recent review of this, just published in the last month or two, looking at this question in more detail. And there's an ongoing chemotherapy study actually taking this into account, ongoing in France, looking at patients who've had chemotherapy with using this temozolomide regimen, and whether or not this MGMT is present or not present, and seeing what the outcome is for chemotherapy in light of this methylation. And so we'll have to, and this will give us further understanding of whether this is something we should be taking into account when we're prescribing chemotherapy for patients. This is an interesting trial along the same lines with the drug capecitabine and temozolomide. It's ongoing in Italy. And the question is this is in patients who've got high-grade neuroendocrine tumors, a neuroendocrine carcinoma or NET G3 with a Ki-67 of over 20%. And in patients who've already had platinum chemotherapy, can you give them, what's the best treatment if you've failed or progressed through platinum chemotherapy? Does capecitabine temozolomide work, or is FOLFIRI, a different chemotherapy agent, better to use? And within this study in Italy, they're looking at PET imaging as well as other biological markers to see if that can help in predicting. So this is a trial which we'll report in a couple of years' time, but it'll help us decide what's best for neuroendocrine tumor high-grade patients. Within the UK, there's the NET-02 trial, which is currently ongoing, just recently started. And that's looking, again, in high-grade, poorly differentiated neuroendocrine tumors of pancreas and intestine. And it's second line after patients have had platinum-based chemotherapy. And it's looking at liposomal irinotecan, one drug, with 5-FU and folinic acid, versus another drug called docetaxel in high-grade neuroendocrine tumors to see if one combination is better than the other. And so this, again, the more understanding we have and more options, particularly in the more aggressive high-grade neuroendocrine tumors, the better. You know, high-grade neuroendocrine tumors are often all lumped together and say, right, you've got a high-grade neuroendocrine tumor, you're going to have platinum chemotherapy. This recent research, again, that's just come out in the last couple of months, so you just can't lump everyone together. And here you can see that there's a difference between high-grade neuroendocrine tumors from the cervix versus, for example, small cell lung cancer. There's different genes that are expressed. There's a different genomic profile where the high-grade neuroendocrine tumor is from one origin, the cervix or the lung. But also, actually, even within the cervical neuroendocrine tumors, the high-grade neuroendocrine tumors, if patients were human papillomavirus positive, ladies positive for this virus, actually there were different gene expression to those who are HPV negative. And so therefore, actually, again, there'll be different treatment considerations and maybe different responses as to the origin, virus positive, virus negative, where the tumor originates. And I think we have to understand this better to get better results in patients with a higher grade neuroendocrine tumor. So this is giving us important information that we need to be understanding more and looking further in terms of the biology and the cause of these neuroendocrine tumors. Moving on to PRRT, peptide receptor radionuclide targeted therapy. You're well aware of this, very exciting, based on the gallium PET scan lights up the tumors as hotspots. You change the gallium for a stronger radioactive particle, yttrium, more commonly lutetium, which is a beta emitter, goes into the tumor cells. You kill tumor cells that way. And the NETA-1 study had previously shown significant survival benefit and progression-free survival. So 79% reduction in the risk of disease progression or death in the treatment group with PRRT. Remarkably good response as opposed to patients who were in the group that were on high-dose octreotide at 60 milligrams. You did have some benefit, by the way, of being on the high-dose octreotide at 60 milligrams. But there was a survival benefit in the interim analysis in this group treated with PRRT. And here's a nice example of a patient who did very well with the PRRT, these hotspots being treated very successfully. But not only did it have an impact in treating tumor, it also improved quality of life in terms of global health status, but also controlling symptoms such as pain and diarrhea as well, with very good toxicity. And that's the appeal of the PRRT. There's the sustainability of results over 2 or 3 years before the tumor might consider growing again with limited toxicity. And that's also been translated into pancreatic neuroendocrine tumors. Hence it's licensed for both intestinal and pancreatic neuroendocrine tumors. It's a patient multiple lesions, and after PRRT just had 1 lesion which was resistant. We in fact burnt that away with radiofrequency ablation, and the patient's done well subsequently. And PRRT works well for bronchial, pancreatic, midgut, and even tumors of unknown origin. And even for pancreatic neuroendocrine tumors, there were improvements in quality of life as well, including diarrhea and gut disorders, as well as fatigue, nausea, and vomiting. So PRRT has a very good anti-tumor effect, but also a good effect on improving quality of life. Yes, for the first weeks after neuroendocrine tumor, you can feel more tired. That gradually wears off, but the sustainability of response, overall, you have a better quality of life as opposed to those patients who don't have PRRT. There's an ongoing study at the moment called the COMPETE study, looking at a different form of PRRT, not lutetium octreotated, with lutetium, if you like, octreotide versus everolimus. And this is in well-differentiated neuroendocrine tumors of pancreatic origin, and also of intestinal origin as well, and the non-functioning intestinal neuroendocrine tumors. They have to have a positive gallium PET scan. It's recruiting 300 patients internationally in Europe and Australia and Americas, and comparing everolimus with lutetium. And this will take a couple of years to give us a result. In the UK, there's a study of the NETA-2 study, which has just started, of in high-grade neuroendocrine tumors, Ki-67, between 10 and 55%, so well-differentiated, so G2 and G3 neuroendocrine tumors as a first-line therapy, comparing high-dose octreotide LAR, 60 milligrams, versus PRRT with lutetium plus octreotide at 30 milligrams. And this is ongoing in Europe and in America. So patients with G2 and G3 neuroendocrine tumors may well go into this study or be offered this study in the UK. So the next generation of PRRT is something called the antagonist. So you've got yin and yang, yin being the lutetium octreotate at the moment, and yang will be these antagonists. And the antagonist has higher binding, in fact, to the tumors. You can't see all of them clearly on the dotatate PET scan, but on the PET scan with the antagonist, OPS antagonist, you can see tumors much more clearly than on the gallium octreotate PET. And this is being changed then, if you change this dye to lutetium OPS 202, there's early studies ongoing with this at the moment in the UK and again internationally in grade 1 and grade 2 neuroendocrine tumors, including lung neuroendocrine tumors. So we'll have to see if this works better, whether or not, because it's got stronger binding affinity to the tumors, that may also mean that it has stronger binding affinity to other organs. So we have to make sure that there's no other side effect profiles with other organs. So I've talked to you about what's been historic single agent therapies, chemotherapy, PRRT, somatostatin analogs, and targeted agents such as everolimus. But really, the future is going to be combinations of therapies as well. And that's what the future holds. I just want to finally be talking about the last set of new treatments called immunotherapies, and just talk you through this very briefly. You've got the cancer cells here, and you've got the immune cells, if you like, the lymphocytes here, the cytotoxic lymphocytes, the T lymphocytes, regulatory T lymphocytes. And on the these lymphocytes, you've got the PD-1, so here, it's called programmed cell death 1, a great name, PD-1, and it's expressed on these activated lymphocytes. They're saying, oh, I'm happy to be in this environment. PD-1 is activated, and what PD-1 does, it normally tries to inhibit the cytokines which might kill tumor cells and inhibit ways of killing the tumor cells. So this PD-1 can be activated in the environment of the cancer cell. The cancer cells, look, mate, don't get activated. And by not getting activated, the cancer cell grows and grows. So with their PD-1 inhibitors, which bind then to the PD-1 and say, and stop then this process. So then by doing that, enhances the immune response. And there are these drugs, pembrolizumab and nivolumab, which are PD-1 antibodies, which bind to the PD-1. And so you can treat tumors that way by affecting the immune system. And similarly, for cytotoxic T lymphocyte antigen CTLA-4, again, this is on the surface of lymphocytes. And again, when it's expressed in the environment of tumor cells, there can be a feedback from the cancer cells saying, just quieten down, guys, don't do anything. And by being expressed there with the CTLA-4 and being that we're happy lymphocytes and cancer cells, the cancer cells are going, great, we're growing and growing. But actually, if you turn off CTLA-4 with an antibody that attaches to it, then the immune cells get angry, and by angry immune cells, they can then attack the cancer cells. So you've got CTLA-4 antibody inhibitors, then ipilimumab, tremelimumab. So this is another way of attacking how the immune system can attack cancer cells with these new advances of antibody-targeted therapies to PD-1 and CTLA-4. And also, in fact, you've got PD-L1, because this PD can bind to the PD-L1, which is a receptor on the cancer cell to make it all happy. But actually, if you attack this receptor PD-L1 by immunotherapy, then the cancer cell doesn't get happy, and you can kill the cancer cell that way. And the drugs attacking this receptor, the happy receptor, if you like, on the cancer cell, happy because it can join sometimes with this PD-1 and continue to grow. So if you either attack PD-1 or attack the receptor PD-L1, then you can kill the cancer cells that way. So for immunotherapy, the results have been somewhat disappointing. This is single agent immunotherapy targeting PD-1. It's only shown partial response in thoracic neuroendocrine tumors with very little response in pancreatic and intestinal neuroendocrine tumors. There are some patients where you had seen shrinkage here of the tumor here and here to here and here following treatment and after 4 months. But overall, for single agent immunotherapy, the results have been rather disappointing. Combination strategies with the CTLA-4 and PD-1 or PD-L1 combinations targeting those with nivolumab, ipilimumab seems to be the way forward, targeting 2 strategies of the immune system at the same time. And in early studies with this, you're seeing some benefit in particularly the higher grade neuroendocrine tumors. And again, the results are not outstanding, but in atypical bronchial neuroendocrine tumors, some pancreatic neuroendocrine tumors, you're seeing responses here, which are over 50, 60, 70 weeks or more. But actually for many tumors, the responses were really quite limited. And that was shown again in a very recent study, again, only just published this year, that in terms of immunotherapy, in red, it's the high-grade neuroendocrine tumors that seem to do better than the well-differentiated lower-grade neuroendocrine tumors. And there's another study looking at this called the DUNE study. It's a combination of an anti-PD-L1 and CTLA-4 drug, and this is an ongoing study in terms of its further design, but the initial results from this study was somewhat disappointing, I think, because in lung neuroendocrine tumors, around about, I think was about 8% of patients had clinical benefit and some evidence of response. In intestinal neuroendocrine tumors, these are poorly differentiated neuroendocrine tumors, a bit better, 32%, and had evidence of clinical benefit, some form of response, and pancreatic 25%. Not fantastic results by any means, but evidence that there is some benefit in these very aggressive tumors. And in the overall poorly differentiated tumors, the final group of the most aggressive neuroendocrine tumors, there was benefit in around about 36% of patients. It should be noted that there are common side effects related to immunotherapies as well. So how can we improve the immunotherapies? We want to prime the cells better. We want the immune cells to grow better and get ways of the immune cells getting into the tumor better or break down the inhibitory process or things that are stopping the immune cells getting into tumors. If we can do that, and there are various therapies which are undergoing clinical trials to try and do that, then we can enhance immunotherapy in the future. And looking at various strategies to combine various strategies, again, will be important to enhance immune therapy response. There's a phase 2 study looking at an immune therapy, atezolizumab. Do you know what? For many of these immunotherapies, I can't pronounce the names. Atezolizumab versus bevacizumab, which is an anti-angiogenesis agent. This is something that blocks angiogenesis, tumor blood vessel growth. But this combination was quite interesting in that the immune agent in combination with bevacizumab in pancreatic neuroendocrine tumors, you saw a shrinkage in 20%, and for the intestinal extrapancreatic neuroendocrine tumors, 15%. But more impressive was the progression-free survival before the tumors grow of 19% in the pancreatic group and 20 months in the pancreatic group and 15 months in the intestinal group. And so this combination looks interesting. There are side effects related to it, particularly high blood pressure, and there may be some kidney damage that one has to watch out for. So can we move towards personalized therapy? So in the last couple of minutes, everyone's talking about personalized therapies and targeting for the individual specific drugs. You know, tumors change over a period of time. At the very beginning, these two genes, if you like, were expressed. By the time some years later, 9 years later, the patient had a liver biopsy, these genes were expressed. After further therapy, just some months down the line, different genes were expressed on the bottom panel. So the different genes are expressed at different times. And this again is shown at the very bottom here, that when the patient was originally diagnosed, these are the genes that are expressed here. At the time of the liver biopsy, when the disease was progressing in the liver, a whole series of genes were upregulated here. And then you send off gene profiles and you'll get a whole list of what might come back, which are called actionable mutations. And actionable mutations mean these are ones where drugs can be targeted for specific genes which are highlighted. So these are in yellow. And you can see that this mainly applies to the poorly differentiated tumors, not so much to the well-differentiated pancreatic and non-pancreatic neuroendocrine tumors in this study. And you can see that there's a difference between poorly differentiated tumors, pancreatic neuroendocrine tumors, and non-pancreatic neuroendocrine tumors as to which genes are expressed and how active they are in terms of mutations. And this variability and the fact there's only single actionable mutations that are shown is the limitation currently of the genomic profiling, particularly because if you just knock out one pathway, there are often other pathways which come into play, which cause the tumors to grow. So that's why combinations are going to be the way forward. And so by just understanding one pathway isn't good enough. We need to be able to understand lots of different pathways and have a genomic profiling which can action lots of drug pathways or show that different pathways are activated so you can attack from one end or the other end. I just want to break this down very simply to some work from 2015 from Doug Hanahan's group looking at the biology and the origins of neuroendocrine tumors. And you had low-grade tumors, insulin type neuroendocrine tumors versus the metastasis-like primary and an intermediate grade 1 called MEN1-like or intermediate group. And they showed different biology so that the MLP metastasis-like primary was much more aggressive, had a high Ki-67 proliferation index, whereas the insulin type neuroendocrine tumor were much more like low-grade neuroendocrine tumors. Just remember that aspect of it. As you'll see on this very busy slide, where this group 5 years later were understanding the genomic profiling for these different groups, and metastasis-like primary group was shown to have upregulation of PD-1 and PD-L1, optimization of macrophages, the lymphocytes involved as well, and inflamed lymphocytes. And so this group of patients, then by understanding the biology in much more detail, we could predict, in fact, that this MLP group will be the one to respond best to immunotherapy. So through all this complex understanding of the biology, we'll be able to predict actually which patients will be able to respond better to immunotherapy. Aldo Scarpa for pancreatic neuroendocrine tumors done whole genome analysis. And this is really interesting because he identified then 4 subtypes of the genome landscape: DNA damage repair, chromatin, mTOR signaling, and this what's called altered telomere length. But you could target each of these with different drugs, as outlined in yellow here. For chromatin remodeling, another drug, PARP inhibitors, tazemetostat, again for this area of subtype of neuroendocrine, pancreatic neuroendocrine tumor, genomic profiling, and here for the mTOR pathway, everolimus. So by understanding this whole genome, you can target drugs depending on which one is overexpressed to the area which is overexpressed. So if this area is overexpressed, mTOR inhibitor, you give the patient everolimus. This area is overexpressed, you give the patient a PARP inhibitor or other form of chemotherapy. So in conclusion, there's exciting progress in the biology of understanding of neuroendocrine tumors. I've shown you that there are new biomarkers which could be potentially prognostic and predictive. There's advances in imaging. We have to be considering surgery for high-grade neuroendocrine tumors, and is there a role for debulking surgery in these patients with even high-grade neuroendocrine tumors? There's lots of new understanding and new clinical trials out there. We've discussed genomic profiling, the information about single actionable genes perhaps not being enough, that actually the more mutations you have, then perhaps the more likely immune therapy is going to work. But actually, I've tried to express the difficulty and the need to understand the whole immune environment better so that we can predict which patients are going to respond to immunotherapy. And it's a little bit like TB or HIV in that it's where there's often 3 drugs which are combined, or 4 drugs combined together. That's more likely to have a more sustained chance of a response or even cure, so that we can knock out different pathways for tumor growth. The question is, will pharmaceutical companies enable combinations of drugs from drug company A and drug company B? Is it in their interest to do that? Often it's not. And so pharmaceutical companies have made fantastic progress for drugs for neuroendocrine tumors. And they're doing great work with supporting research, but also it can be a little bit in their own interest. And we need to be able to open them up to say, well, we want to do combinations of drugs as well with pharmaceutical company A and B. And that's where the voice of the patient is crucial, and why patients really need to be on all committees deciding clinical trials. So finally, I know it's been a complex talk, and rather than just listing trials, I just wanted to give an idea of what the future holds, the complexity of it, but that there are, by understanding that complexity, we can hone down and define the best treatment options for our patients and combinations of treatment. I want to thank our researchers and the funders of research, but most of all the patients for allowing blood samples and for tumors to be stored in biobanks, so crucial to taking forward this research, and for our patients for participating in the clinical trials. So thank you very much, and it's been a great honor for me to be able to give this talk today. Thank you.